Chronic fatigue syndrome and depression, separate or linked entities. I'm Dr. Martin Rutherford. I'm a certified functional medicine practitioner, retired chiropractor, having been in practice since 1979 and recently retired.
Absolutely. Dr. Randall Gates, board certified chiropractic neurologist, also a chiropractor.
In melding our two disciplines, we have come up with our algorithm for chronic pain. And this is what we're doing every week. We're sharing with you what we see. Dr. Gates is basically our research and development department. He does a tremendous amount of research to fine tune what we do. And so we've put together our unique, I would say, a logarithm that continues to be tweaked and tweaked based on that research in an effort to continue to help our patients to do well and get improved and so on and so forth. And these are the things that we're sharing with you week by week, what we see here in hopes that it'll be helpful for those of you who are patients or those of you who are sufferers, those of you who are clinicians. We've had interaction with all of you, and it's been really wonderful. So chronic fatigue syndrome and depression. We started out treating fibromyalgia in our endeavor to understand chronic pain. Pretty much every fibromyalgia patient has chronic fatigue, to the degree where when I talk about chronic fatigue patients, half the time I'll call them fibromyalgia patients, even though not all chronic fatigue patients have fibromyalgia. So the point there is, these are complex matters. These are multiple vicious cycles that confuse doctors, frequently leading patients on a trip of that can be it can involve a number of indignities. It's in your head. It's these types of things, and some of the other things that get involved regard you frequently being diagnosed with depression. We are going to elaborate on that. I will say that we treat a broad spectrum of chronic diseases, most neurological, but we treat chronic stomach problems. We treat chronic dizziness, vertigo, balance, restless leg. We treat chronic thyroid problems. We treat chronic fatigue.
Peripheral neuropathy.
Peripheral neuropathy is one of the biggest ones we treat. And virtually all of those folks come in and mark depression on their intake. And we were just talking about when we went to school, the pathology books, Robbins and Rubens were our encyclopedic Bibles for those. And pretty much in pathology books, you read about all of the different disease entities, and pretty much the first symptom of every one of them is
fatigue,
which
you had a lot of going through school.
which I had a lot of going through school. Yeah, as a student, you had a lot of going through. So we're going to discuss fatigue, depression, linked, and maybe a little bit more specifically so you can understand these. I mean, I would say most of our patients that come in who do well, which frankly is most of our patients, their depression frequently is either gone or substantially improved. And almost technically, you can almost say you're not treating them for depression.
Right, we're treating all the other things associated with the depression.
So let's talk about chronic fatigue syndrome. When a chronic fatigue syndrome patient comes here, and I do the intakes, but Dr. Gates does an extensive history once we get into the exam part of our evaluative procedure. What do you find that most patients are commonly told about their chronic fatigue syndrome?
Most patients are seemingly healthy. You know, they don't have anything majorly wrong with them. So they go to their general practitioner, and the general practitioner says, oh, you're fatigued, you must be depressed. And so they start asking you questions, you know, are your sleep patterns off? You have no motivation. Well, and you'll say, well, I'm not feeling sad. And they'll say, yeah, but you're depressed. Because in their mind, you're fulfilling the criteria set forth for them by the overseeing medical communities that you have depression. So they're going to put you on an antidepressant. And lots of times patients feel frustrated by this. They may be angered by this, but you just got to understand where your doctor is coming from, because you're saying, no, I'm fatigued, I'm not depressed. Or maybe I'm a little depressed, but that's not my major problem. And so that is one area that commonly patients will go into.
And their solution is to tell them, you're depressed, so
you need an antidepressant.
go to a psychologist.
Or you need to go to a
Go to
psychologist. If you don't
counseling.
want to take the medication, you need to see a psychiatrist. Yeah, things of that nature.
Yeah. So this is very disturbing to the patient, as frankly as it should be. I've often argued that the doctor should just have the integrity to say, look, I don't know what's wrong with you, and not create a more perpetuating problem by basically starting to get this patient to wonder, is it in their head? Which it usually is not.
Well, the interesting thing is, because we associate with other medical doctors, and frequently they don't believe in chronic fatigue as an illness. They don't believe in it as a diagnosis. So that also creates further friction for the patient coming in who has suspected chronic fatigue. And then, of course, you've been reading on the internet, right? And so you come in saying, well, I read that Epstein-Barr can cause this, or I read heavy metals can cause this, or I read this chronic infection can cause this, or it's my adrenal glands. And we're not laughing at you. We're with you 100%. But to the mainstream medical doctor, that's just not even in their universe for the most part. I'm not saying all medical doctors, but generally within the diagnostic realm, they're not thinking those things. So that's going to also, typically in my experience, patients come back to us saying, well, we got into a verbal argument over those matters.
Yep.
Yeah, that's common.
So in this presentation, we're going to argue that the patient who comes in with chronic fatigue syndrome and depression, that these are actually linked. It's not that the patient is depressed and they're psychologically feeling all of these things, or that they have some sort of a psychological syndrome. They are depressed. And when we do the interviews, the patient will frequently say, well, yeah, of course I'm depressed. I feel like this. And I will say, well, there's actually a physiological problem that's causing you to be depressed. And it has a crossover with the problem that's causing you to have chronic fatigue syndrome.
Right. And I just want to interject, not to interrupt you, that these are distinct but overlapping entities. That's really, they are linked.
And that's where I'm getting
they're
with
separate.
this.
Yeah, exactly. I just want to, before people start throwing their shoe at the
TV
screen.
No, there's depression and there's chronic fatigue. But what we're saying is, okay, so the string we're pulling is, you go to the doctor says, your problem, all your tests are normal. Nothing's on your MRI, nothing's on your CAT scan, your x-rays are normal, your blood tests are normal. You need to go see a psychologist.
Right.
Because you're depressed. Mm-hmm. That's what's causing all of this. Okay. What we're saying is that's not true. Mm-hmm. There are other types of depression, is what Dr. Gates is saying, or other
components of
depression. What we're talking about is there are common components in neurology and in physiology, which we would call metabolic issues, okay, that actually create that depression. So why don't you expand for the audience and me what the underlying biology, and I would say neurology, is of both illnesses, delineate the similarities and maybe even some of the differences.
Yeah, and I recommend the viewers, if you want to kind of be active with this presentation, you can even get out a piece of paper and a pen and write down these entities, because it's good to look at them on paper. Because for a chronic fatigue sufferer, here are the main things that are going through our head when we're evaluating you in terms of what is causing your illness. Why are you fatigued? It could be one or several of these things that I'm about to list off. So it could be gut bacteria, believe it or not. So there are studies showing that chronic fatigue patients have different gut bacteria than those who don't have chronic fatigue. We also see that, very similar to many other illnesses, that pieces of bacteria in the chronic fatigue patients break off at too high of a rate, go into the bloodstream. This creates a lot of inflammation, and that by itself can generate chronic fatigue. And we've seen chronic fatigue patients, I've mentioned it in other broadcasts, where they come in here, they've had chronic fatigue for 35 years. We fix their gut, and like in 3 weeks, their chronic fatigue is gone. Now, I wish all patients were that easy, but that's not the case. So that's number one. Number two is, do you have an autoimmune issue? Now, there are many different autoimmune and connective tissue disease illnesses. So patients with rheumatoid arthritis report fatigue. So you have to differentially diagnose something like that. Then we have the infamous Hashimoto's thyroiditis, which is where the immune system kills the thyroid. This is really the most common autoimmune disease. And with this, we're seeing it more as like the canary in the coal mine, as we mentioned frequently in these episodes, where the immune system is breaking down for a lot of Americans. Their ability to prevent their immune system from attacking themselves, those checks and balances are no longer working. And the most common tissue to be affected, as you've been saying for 7 years, is the thyroid. So that has to be differentially diagnosed. The mitochondria for a chronic fatigue patient are highly important. So the mitochondria are the little parts of our cells that make energy. They're commonly referred to as the powerhouse of the cell. And what we see in some chronic fatigue patients is that these mitochondria, the outer membrane of the mitochondria will break down. It's no longer working, so they can't make energy from that mechanism. Frequently, that happens due to a chronic viral infection, but not always in our experience. Right. And then anxiety can be associated with chronic fatigue. And then the infamous adrenal glands, of course, can be associated with chronic fatigue as well. And the adrenal glands, we've done lots of broadcasts on this, are completely ignored at this point within endocrinology in the medical field as it pertains to fatigue. So unless you have a horrible condition called Addison's, where your immune system is just assaulting your adrenal glands, they're going to say your adrenal glands are pretty much normal. And I think I pretty much covered all of the issues except for thyroid conversion. So then another piece to the chronic fatigue patient is, are they converting their inactive thyroid hormone made from the thyroid gland to active thyroid hormone? Most of that conversion happens in the liver and the gut. And frequently insurance companies do not pay for all these tests to be run. So you may be told that your thyroid is normal, but in actuality, though some of your thyroid tests are normal, other aspects of your thyroid physiology are not normal.
So this is the complexity of chronic fatigue syndrome. And I point that out. We're very conversant with chronic fatigue syndrome because the gentleman who originally termed it, Dr. Peterson, who lives up 30 minutes from here, we're in Reno, Nevada. He lives up in Lake Tahoe. Mm-hmm. and it was all about Epstein-Barr at that point in time. So this is chronic fatigue. You mentioned thyroid, adrenals, gut, blood sugar.
Yeah, absolutely. I mean, some patients think they have chronic fatigue and they say, yeah, I feel pretty good in the morning, and then I come in the afternoon and I eat lunch and then I'm fatigued. Well, they're insulin resistant, so they have a blood sugar problem.
So this is chronic fatigue. Now, when people come in and start, and depression is actually mentioned, it's interesting. Most of the patients either don't mention it, they've marked it off on our intake form. They don't mention it, maybe they're embarrassed, but most of the time I think they don't get the physiological connection. And the thought pattern is, yeah, I'm depressed, I feel like crap, nobody knows what's wrong with me, they're telling me I have to go to a psychiatrist. Yeah, I'm depressed. And I'll say, you are depressed, but in our world, in the functional medicine and in the functional neurology world, depression is, and then I'll tell them what it is. Mm-hmm. Why don't you share them what the physiology of depression is and how it overlaps with chronic fatigue?
Because lots of times people will say, yeah, I'm just sad, or I have a chemical imbalance, because I saw that on TV, because that's what the pharmaceutical commercial talked to me about.
Well, take my drug and correct the chemical imbalance.
Exactly. So I have a chemical imbalance. And we need to go into the whole chemical imbalance thing. So you can go back and watch our depression broadcast. I think we did it at the very end of 2015, maybe it was the first week of 2016. Just go to powerhealthtalk.com, search depression, it will come up. But in essence, with depression, the main physiology you need to get is that, well, let's take a step back. With the advent of antidepressants, basically they realized with some chemicals that they were using on mice and then other people way back 50 years ago, they realized that these chemicals cause people to feel happier and feel better. And so that generated the chemical imbalance model of depression that we've been using ever since then. However, researchers were kind of always flabbergasted by the fact that they would give someone an antidepressant, which should have an immediate effect on their neurochemistry, but it would take weeks for them to feel better. So they just thought, well, this chemical had to build up in the system. What we now know is that depression is largely due to an imbalance between 3 areas of the brain. One is the fear area. And this fear area, think of it as like the evil dictator. And then you have your frontal lobes, certain areas of your frontal lobes. Frontal lobes are a big area, but certain areas of your frontal lobes. And the memory area is right next to the fear area. Your frontal lobes and your memory area are really trying to keep the fear area in check. What happens in depression, the fear area seems to go unabated, the brake pedals are off, the fear area starts making lots of cortisol. The cortisol feeds back up into the brain, and it, in essence, kills brain cells in the memory area, as well as the frontal lobes.
And cortisol is
a stress hormone.
It's a stress hormone. So what he's saying is that you're in a chronic stress pattern. You might know it as a chronic fight-flight pattern. It might even be some degree of a post-traumatic stress syndrome, which I think we're going to touch on a little bit later on. But your brain's putting out stress hormones all the time, correct?
Exactly.
Okay.
And what we see with these chemicals that are largely used as antidepressants is that they have the propensity to grow new brain cells in your memory area particularly. And so that's what they've seen, because your memory area is one of two areas in your brain that actually grows new brain cells on a regular basis. So this was kind of the exciting new news in the antidepressant depressed world over the last 5 to 10 years, but it's really been accepted in the last 5 years particularly. But within this model, then a lot of psychiatrists were begging the question, I have these patients taking antidepressants. Some get better, yes, and some stay better forever. I have a lot who then need like another antidepressant or need multiple antidepressants, or they seem to fail antidepressant therapy, so they need counseling. That's not working. Do they need electroconvulsive therapy where they, this is like the electroshock therapy that people talk about. And so they started begging questions as to what are the other factors associated with depression. Very similar to kind of how I listed other factors associated with fatigue. These factors with depression include gut bacteria, believe it or not. We did a whole broadcast on it. So we're seeing that depressed patients have different gut bacteria. Your gut bacteria make bacterial poop, if you want to think of it that way. And the byproducts from these bacteria go to the brain and can really powerfully affect the brain. Things like autoimmune conditions, Hashimoto's thyroiditis. When the immune system is inflamed against the thyroid, it affects blood flow to the frontal lobes. Genetics absolutely can be associated with depression. So can childhood trauma be associated with depression, anxiety.
Concussions?
Concussions can be associated with depression. Hormones can be associated with depression. Obesity can be a major factor associated with depression, because the fat cells, as they grow and we get more voluminous, they make inflammatory chemicals that go up to the brain and don't allow your brain, particularly your frontal lobes, to function properly.
Okay, and I was just going to say, so all this uniqueness occurs. In other words, the quality of our mental state is defined in our frontal lobe. It's a matter of our frontal lobe functioning abnormally. Okay, so this is our frontal lobe. Mm-hmm. And so what I'll tell people when they come in is, I'll say, you're not depressed, you have a bad frontal lobe.
Mm-hmm. And because that's how we look at it.
Because that's how we look at it. That's called functional medicine. Your frontal lobe is not functioning normally, either because there is damage to it, the concussion, that affects something called the blood-brain barrier, which is supposed to keep all of the things that Dr. Gates just got done talking about, all those inflammatory chemicals and bacterial chemicals. They're supposed to keep those out of the brain because they don't belong there. Mm-hmm. So if you have a concussion, that kind of ups the ante, ups the game, makes it more likely, correct, mm-hmm. that you would get depression. Mm-hmm. But then the rest of these chemicals assault the brain, particularly the frontal lobe, and the frontal lobe needs what to be functioning normally?
Definitely needs plenty of oxygen, adequate levels of glucose, and low levels of inflammation.
Right. So if you don't have those chemicals, and all of these destroy those chemicals, right?
Right.
So if you don't have those chemicals working right, depending on what's happening, you might have anxiety and panic attacks, or you might have depression. But they're all a function of, there are different entities that would contribute to panic attacks, anxiety. We're talking about depression right now. So you have a poor frontal lobe, mm-hmm. and it's either been damaged or you have poor chemistry. And one example that I have found works is when people have a hard time going, I'll say, when you have low blood sugar and you don't eat for a while and you get irritable and shaky and you start snapping at people,
that's a perfect example.
That's poor chemistry in your frontal lobe.
I think there's even a new word for it called hangry. I don't know if it's been approved by Webster's dictionary, but yes.
All right.
That's it.
So this is depression. Mm-hmm. And this chemistry overlaps, as you see, substantially mm-hmm. with chronic fatigue syndrome. And you started to talk about childhood traumas. Did you want to elaborate on that?
Yeah,
because
absolutely.
Those tend to exacerbate that amygdala. What did you call it? The villain
Yeah, it's
the
the evil dictator.
The evil
Evil
dictator.
yeah.
It's your fear center. And ironically, it's a survival mechanism.
Absolutely.
So it's there for us to become fearful when there's a need for us to fight the danger or flee the danger.
Mm-hmm.
But when people have depression, theirs is not shutting down after the danger is gone, correct?
Exactly. Or it's
what
primed
happens?
to fire off too much. So what happens is that going back to childhood trauma, it's very interesting because childhood trauma links in with so many
Because we see this every day.
We do see it all the time. And this is just not commonly discussed in the medical world as it pertains to chronic pain and chronic illness very commonly. And that's one of the major problems, frankly, that we're finding, is that these associated psychiatric and psychological mechanisms need more attention because they're driving the boat, so to speak. So if an individual is exposed to childhood trauma early in life, then this fear area tends to get primed. It tends to become overactive. It becomes well learned. So the rest of this individual's life, they're creating stress responses that are not correlating to the level of stress in their daily life. So for example, they may be creating a stress response that's 30% greater than someone who hasn't been through childhood trauma. And over time, that takes its toll on the body through a number of mechanisms. Cortisol can affect a number of systems stress like the gut, stress hormones, things of that nature. We actually attached an article today. This was very interesting, brand new. Individuals with childhood trauma, it actually changes their genetics for stress hormone receptors.
Say that again.
So individuals who have been exposed to childhood trauma, usually this is sexual or emotional abuse or emotional neglect in childhood.
Perfect.
It changes their receptors for stress hormones genetically.
Okay.
So this goes to the argument of epigenetics. So everybody is fixated on, well, what are my genetics? Well, your genetics matter to a certain degree, but lots of times it's the epigenetic regulation of your genetics, meaning what circumstances have you been exposed to in your life to then cause your genetics to express certain factors.
Okay. So in lay terms, our frontal lobes need proper oxygen, mm-hmm. lack of inflammation, mm-hmm. proper blood sugar to work right. You don't have those, you're going to have some sort of emotional, is what we call it in our world today, which I hope is going to change, reaction. You're going to be depressed. Okay, there are other things you can feel. We're talking about depression right now. The brain also needs proper stimulation. Mm-hmm. The brain lives by stimulation, right? Mm-hmm. Sensory stimulation, mm-hmm. You smell, taste, touch. The brain receives stimulation and then it stays stronger mm-hmm. when it gets that. But when you have any of these entities, you have a gut problem, you have a thyroid problem, mm-hmm. you have blood sugar problems, you have stress hormone problems, you have all these problems. The threshold for that brain's ability to withstand normal stimulation is now here. And now you throw on childhood trauma, mm-hmm. which increases, or that even 30% mm-hmm. more, if I understood mm-hmm. you correctly. And now something that normally your brain would look at and kind of go, ugh, that doesn't look right, and would walk away from it. Now you might go into depression mm-hmm. or even, and we're not talking about anxiety or panic attacks, but your stimulation, which is always the same, now is meeting a much more sensitive threshold, and now you're into depression because of chemistry and maybe because of mechanical damage, like a pathology can cause it, a brain tumor or something like that. But we're talking about stuff that people have got their MRIs and they've already been told they're normal. So concussion and or all these chemical issues that have been told. Right. That's depression.
That's depression.
Is that correct?
That's correct. And then the childhood trauma not only links in with depression, childhood trauma gives you a 6 times increased chance of developing chronic fatigue later in life, which is astounding. When we
it is astounding.
Look at a lot of associations like smoking relative to breast cancer, those associations can be 1 or 2 times. Don't quote me on that. I'm just giving you an example. I think the association with smoking and lung cancer is about 16 times increased chance, but a 6-fold increased chance of chronic fatigue later in life if you've been exposed to childhood trauma is rather significant, and people need to be asking these questions if you're a chronic fatigue sufferer looking for answers. And then go ahead. I was going to.
No.
Yeah. And then this brings us into the area of the
Okay.
HPA
Okay.
axis.
So and if you're suffering from depression and you're watching this, don't feel alone. There's 130 to 160 million chronic pain patients in this country, according to let's say the Stanfords and the Harvards and the National Health Institute and the people who keep track of this. Those are the latest estimates. So if you look around and go, it's normal or it's old age because everybody's got it, it's not. It's just that this is what society is creating, and that's a whole nother talk. Now, you have it. You understand now it's a chemical issue. Dr. Gates briefly alluded to the fact that the medications changed brain chemistry, and they had some confusion on it because it took a while. What are the treatment solutions? And I would kind of compare and contrast the medical, and we're not anti-medicine. We're going to say that right now. We are not. We work with medical doctors. We work with neurologists, cardiologists. We work with pretty much anybody who will work with us. And if it's required for that case. And so there's a fair conversance here, even though we're not medical doctors, with the medications, because we have to be aware of them. What we're doing is changing chemistry, and we have to be aware of the chemistry that's going into the person's physiology. So what are the solutions for this? Maybe a little compare and contrast of the drug model versus what can be done without medication.
So I would say first, if you're wanting to be interactive, I would draw a boat on your piece of paper that you've got out, and then draw holes in the boat. And you can draw like about 8 different holes. And maybe you want to draw 2 different boats, because one boat is going to pertain to depression, one's going to pertain to chronic fatigue. And so for the fatigue sufferer, in terms of treatment, in terms of the medically based treatment, maybe it's an antidepressant. Maybe they'll put you on like a weight loss medication, like an epinephrine derivative, to see if that doesn't give you more energy. Beyond that, they may send you to the endocrinologist just to have your hormones looked at. Most of you come back though with normal hormones. Maybe you're on a little thyroid medication, but it's not making a difference. So that's when you start seeking alternative therapies. Now, that's a whole nother discussion unto itself, so I'm going to stop there. But relative to you, what you need to know as a chronic fatigue sufferer, based on literature, with these holes that we talked about, you need to be looking at your gut bacteria. You need to be looking at, are pieces of bacteria breaking off, going into the bloodstream? You need to look at other autoimmune problems, including Hashimoto's thyroiditis, which most of you won't be tested for. If you are tested for, in our experience, the lab range is not correct, except if you're at the Mayo Clinic or locally here in Reno, and especially in California, most labs are saying 9 is the high value for the thyroid peroxidase antibody count. So you need to factor that in. Then you also have to factor in the mitochondria, like we talked about. You have to factor in exposure to chronic infections. It's not just Epstein-Barr, it could be a number of things. Lyme disease is a possibility, but we find that with Lyme disease, typically it's more of an autoimmune problem than just an infectious issue. And then you have to look at the adrenal glands, yes. And you have to look at the thyroid conversion levels. And through a thorough history and exam that we talk about frequently, you figure out which one of those holes is a bigger hole.
You're answering my next question. My next observation and question, and probably last one, is that doing the intakes here, a lot of people now, this wasn't the case as little as 3 to 5 years ago, but a lot of people now are going to be watching this and going, I already looked at all that. I already did that diet, and I already looked at this, and I already looked at it. It didn't work. So, I just read a book that a patient gave to me yesterday, and I read the history of what this lady did, and we'll probably have to do a presentation on bone broth. But she went to stretching and bone broth and got much better. Okay, well, and so she went through all that. She details a history in which she was told she had leaky gut, she had food allergies, she had Hashimoto's, she didn't have Hashimoto's, et cetera, et cetera. So just for that particular listener who might be there, because if somebody's watching this,
and saying,
they have probably been searching.
True. And so you may have done all those things, but did you do them all at the same time? Did you do them in isolation? What I will say within kind of the paradigm of this model is, if you still have one hole in the ship, you're still taking on water, and you're not going to be better as a chronic fatigue patient until all of those are fixed. Also, there are a lot of people out there touting their leaky gut solution or their probiotic solution. We do this all the time. We've been doing it 10 hours plus a day for coming up on 7 years, not to, you know, sound self-laudatory, but I'm just telling you, and we've done the research, so we have had the privilege to figure out which treatments are really effective and which ones are perhaps bogus. So there are many people out there on the internet now trying to sell you supplements for the leaky gut solution, or the Lyme disease solution, or the mitochondrial solution. You may do that, but in our experience, we see a lot of you come in here until you fix all these pieces of the puzzle individually and with a high degree of specificity. For example, if you have leaky gut and we're not fixing your brain pattern, it's probably not going to resolve long term. So that's my answer to that question.
And here's what I would also say, maybe that seems to communicate with patients that ask me this question. You can have gut problems, autoimmune problems. You can have overfiring brain giving too many stress hormones. You can have mitochondrial dysfunction causing in and of itself fatigue. You can have adrenal fatigue, thyroid, all these different things. But not everybody who comes in here with chronic fatigue has all of those. Everybody's different. We say treat the patient and not diagnosis. This is why. But in addition, so before you start attacking your case, you need to know which one of those are for you, and then you need to know what hierarchy, what order in which to attack these. Because what the research shows and what we have found to be true is these are multiple vicious cycles. It's not one thing. We did a presentation called "There Is No Silver Bullet," and that means there's no drug and there's no supplement, one solution, because these are multiple problems. And if you find the right one or two, and you do them properly, maybe even synchronous, maybe at the same time, you'll find multiple of these other cycles that you're throwing everything in the kitchen sink at will resolve relative to your chronic fatigue and your depression by treating, let's say, the brain and the stress hormones and the gut, where many of these entities are, and 70% of your nervous or your immune system resides. So maybe by treating those two at the same time, so that the stress hormones aren't sabotaging what you're trying to do in the gut, now maybe you get 70 or 80% better. Now maybe there's one or two things left to take care of, and maybe there's not. So that is, to me, that is the landmine on the internet.
Right.
On the internet, it's like all the stuff's all over the place. Try the next great thing. Now, I'm not saying bone broth for all you out there. I'm saying it has no value, okay? But as I read this lady's very sincere book and very enthusiastic and very excited about bone broth and stretching, I've had dozens of people come here who've tried bone broth and stretching, and it's done nothing for them. So she was fortunate. She hit the lottery. You know, she hit the lottery. Okay, so is that an accurate description?
That's an accurate description.
Dr. Gates
for sure.
does all the treatment also. Is that an accurate description of how you go after this? And I say this because we get consistently successful results. We know what we know, we know what we don't know. So we share with you what we know, and we share with you what we have seen be successful day in and day out. Chronic pain is not an easy task to take on. If your desire is to get the person under control in 4 or 5 or 6 months and give them the tools to stay better, as opposed to most of what we see going on out there, which is, okay, you're in chronic pain, we're going to see you forever. We're going to try a little bit of this, we're going to try a little bit of that. Well, frankly, you can do that watching the internet. You can do that yourself, okay? So this is depression. This is chronic fatigue. They both have a problem right here. They both have chemistry right here. If you've had a concussion, that probably also has, that has kind of a physical detriment to the brain. And so you're not crazy. And you probably have a chemical or physiological imbalance in your frontal lobe.
Absolutely. It's very common.
When your brain gets bad, you get tired.
That's true. And one thing we didn't go into
I
is
can attest to that.
the HPA axis, which is where your brain, that fear center, talks to a part of your brain called the hypothalamus, which then talks to the pituitary, which is the master gland in the body that sends all the chemical signals down to your hormone producing glands. And that can become disrupted, especially in not only depressed patients, but also chronic fatigue patients. And within the literature, everybody wants one thing for one condition. So they want depressed patients to have high cortisol, and they want chronic fatigue patients to have low cortisol. And while that is generally the true, there are overlapping features again. So we see some depressed patients who have low cortisol awakening responses, others who are just burning out their cortisol all day long. And so you have to understand all these variables. You have to understand that research is great, but it does not fit every person. Individuals don't come out of the textbooks, unfortunately. And so that makes life more interesting for physicians practicing in this model. But I think that pretty well covers this discussion. It's a Venn diagram. There are overlapping features. And if you want more information, again, go to powerhealthtalk.com, search depression, search chronic fatigue, search gut bacteria. We have hundreds of videos up there. Well, between YouTube and our Power Health site, we have a lot of videos. So thank you for watching, and we will see you next week.